This.
Kanakwel, we can't hear you. Dr. Kanakwel.
Sir, am I audible now, sir?
Now you are audible. Yes,
yes sir. We are starting, sir. Good evening, friends. We warmly welcome you for this edition of the PG Clinics. We have two important cases to be presented. One is the case of breast tumor, kindly contributed by the team Anand Saki sir and Yadav sir. Both of them are from District Hospital in Vijaypura. And Palakmar is not new to us. He has 3 years before he has presented once when he was a first year resident. And I thank the kind efforts taken by Professor Nishikant Gujar sir to get this organized. And the other one is Dr. Shubham Gupta. He has also been with us some 2 years before. He is from Kanas's department, the IMS PH Varanasi. He is going to speak to us about epigastric mass. So I requested both the Vijaypura team faculty to join us as guests today. Welcome both of you, sir. And we have Professor Anandi Madam from Stanley, Professor Shamita Ma'am from IPGMR Kolkata, and Dr. Shilpa Rao Ma'am from Professor Shilpa Rao Ma'am from SETGS. And I also warmly welcome our senior faculty here, Kanna sir, Raj Gopal sir, Rajiv sir, and other seniors who are being with us. Friends, we will be going ahead with the thing. The first case, as the faculty wanted to have the breast case as the first case. So I've requested a candidate from Vijaypura, Dr. Bala, to start his presentation. And the plan will be to start for breast case first, goes for 1 hour, and then remaining 1 hour will be for the epigastric. And all the faculty have been with us earlier. So it will be first half an hour of clinical part and second half an hour of management and complications in that order. I request the faculty to give the answers if the candidate finds to answer it to your satisfaction so that it becomes a teaching format. And also put on record, 2 of our students have got gold medals in their MS exit exam. So I thank all the faculty here and students for making this possible. In fact, remote colleges from Baroda, remote colleges from Imphal and all have participated. And few of them, our students who are presented, have taken the membrane quiz. They've 5 teams have been informed that they were part of this and they got selected, and 2 of them have gone through the finals.
Why?
So these are the information, and with that few information, we move on to the. I request non-participants to kindly mute themselves, please.
Okay.
I could see. Thank you. I'm sorry, I had to force quit them. So, Bala, you please start your PowerPoint and start your presentation. I think Dr. Anand Salki sir, you've been mentioning that you are not able to hear us. I request you to log out and come in once, sir. Most of the time that gets sorted out, or to upgrade your Zoom to the latest version and try, sir. I hope that sorts out your problem, sir. I request you to log out and log in. Most of the time that helps you to sort out. If not, you please upgrade and please come in, sir. And I'll also put the YouTube link here. Those who are unable to come into the Zoom can use the YouTube to come in. Bala, we are unable to see you. Can you switch on your video?
The video is on, sir.
Perfect, perfect. Make it full screen. Good luck to you.
Yes,
all the best.
Yes, thank you, sir.
And don't hold the clinical picture for a long time, because a
Yes,
couple of weeks before our video got banned, one of the CA breast case. So I request not to hold more than 10 seconds, and then
yes,
you can swap and come back again if you wanted to do it.
Yes,
Faculty, please take over. Thank you very much.
So shall I start, sir?
Please, sir. Good luck to you.
Thank you, sir. Good evening, everyone. My name is Dr. Balakmar, final year surgery resident. My moderator is Dr. Ashok Jadhav, sir, HOD Department of General Surgery, Vijaypura District Hospital. A 65 years old lady, homemaker, hailing from Bijapur, presented to the OPD with chief complaints of lump in the right breast since 2 months. History of presenting illness. Patient was apparently normal 2 months back when she noticed a lump in the right breast, which was initially of size 2 × 2 centimeter. It rapidly progressed and reached the present size of about 15 × 15 centimeters over the past 2 months. There's no history of fever or discharge from the nipple. No history of trauma to the breast or ulcer over the breast. No history of weight loss or loss of appetite. No history of back pain or jaundice. No history of breathlessness. No history of pain abdomen or abdominal distension. There is no history of headache or blurring of vision. Past history, she's not a known case of diabetes mellitus or tuberculosis or hypertension. She underwent tubectomy 20 years back. No history of hormone replacement therapy intake. Family history, there is no history suggestive of breast or colorectal malignancies in first or second degree relatives in the family. A person history, she consumes mixed diet. Bowel and bladder habits are normal. No addition. Sleep pattern is normal. Menstrual history, age of menarche was 14 years. Regular 30-day cycle with flow for 5 days. Age of menopause was 50 years. P3, L3, vaginal delivery, all children adequately breastfed. First childbirth at 20 years. Cumulative breastfeeding done for 6 years. Summary, a 65 years old postmenopausal lady presented to the OPD with complaints of lump in the right breast, which was initially small in size and reached the present size of about 15 × 4 centimeters in 2 months with no history suggestive of metastasis. I would like to give my differentials as carcinoma breast and phyllodes tumor.
Can we have a brief look at the picture?
Yes, yes, ma'am.
Okay. All right. So, at the age of 65, why would you call it a phyllodes? What is the typical age for a phyllodes to happen?
Phyllodes usually happen in middle years, 30 to 45 years.
So why have you given it as your differential diagnosis?
Ma'am, she has only history of 2 months. She noticed the lump and it reached initially it was 2 × 2 centimeters for her, and it reached almost 15 centimeters within 2 months. And there is no other history. She's not having any discharge from nipple. There is no ulceration, or there is no history, any metastatic history. So I would like to keep phyllodes tumor also as my differentials.
I would like to differ on this, but continue.
Yes.
Before Bala and Dr. Shamita here, before you proceed with your clinical examination, I just wanted to ask you a few questions on your history. The first one, Dr. Shilpa has already said that this age is not classical for phyllodes, but yes, exceptions always prove a rule. Also, you said that the size increased within 2 months from 2 × 2 into 15 × 15. Such a rapid progression, what does it make you think of?
Ma'am, it could be the lump could have been existed already. She had noticed it 2 months back. Following that, if there is any neoplastic conversion in the lump, also could result in this size.
Not so likely. See, when you have such a rapid progression, you have to think of two things. Number one is if it is even a shorter duration, say increase in size within, say, a week or 10 days, it could be obviously an inflammatory or a traumatic lump. Okay? Yes, but since you said it's 2 months and a progression from 2 × 2 to 15 × 15, it usually is a sarcomatous lump. So your DD of a phyllodes has to be kept in mind. But the point remains that 65 years is not a classical age for a patient to have phyllodes. Yeah, but yes, we do get elderly patient. In fact, I have a patient with me at the moment who is 70 years old with the phyllodes. So I was pleasantly surprised to see your case presentation because it matches her. Okay, coming back to you had said there is no history of fever and all that. Fever and discharge. So why fever? Why suddenly did you consider fever?
No, ma'am, if just for completion's sake, and if she's having any breast abscess for that sake,
right. So, but again, a 2-month breast abscess, suppose I just twist the situation, it is a breast abscess, but for 2 months, what sort of a breast abscess would you find, prolonged for 2 months?
Ma'am, I'm sorry, can you repeat?
I said, suppose it is an abscess. An abscess will not be there for 2 months without systemic features like fever, tenderness, pain, redness, and all that. But can you have an abscess which has been there for two months? Is there any type of abscess which you can have, or a breast abscess not due to any acute inflammatory lesion?
Ma'am, in tubercular.
Yes, so yes, you
Tubercular
have to
granulomatous
rule out,
tuberculosis.
yes, either a tubercular mastitis or an idiopathic granulomatous mastitis. They often present as breast abscesses, so they can last for the 2 months that you're talking about. One place where I would like to disagree with you, patients of breast carcinoma seldom have history of weight loss, loss of appetite and all that, okay? So yes, it is a very common history for malignancy in other cases, but breast carcinoma patients seldom have this. You've talked about menstrual history. Remember that in other cases, menstrual history doesn't come right at the end. Okay, so in a breast cancer, put it in your chief complaints because that has a lot of bearing on the patient's history. Okay, yeah.
Okay.
So shall we move on with your, unless the other examiners have something to ask, can we move on with the clinical examination?
Yeah, so in Indian women, what is the usual age of menopause?
Usually 45 to 55.
Usual age is this thing. You don't give me a group. Like, what is the commonest age for getting breast cancer in Indian women?
It is
Age.
postmenopausal.
No. When we're talking about age, as per the ASCO guidelines or the WHO guidelines, it's like when you put in like thousands of patients, there is a particular number that comes up, right? In the Western countries, it is 54 years of age. Okay, that's the age where you have the maximum incidence of breast cancer. In Indian women, what is it?
I'm not sure.
It's a decade younger. So in Indian women, you tend to have
40.
more of women coming in at a younger age group. Okay.
Yes,
yeah. Okay. And yeah, you should mention history of recent weight gain more than weight loss. Isn't that more important? Because history of recent weight gain post-menopause is one of the factors which are risk factors for developing breast cancer.
Absolutely.
Yeah, so you can't just say typically just to complete the history or complete the presentation. It has to be relevant to what your patient has.
Yes,
right? Yeah.
Yes,
continue.
What is this familiar history?
Hala, what do you understand by cumulative breastfeeding?
Sir, the entire all three children, the time period for which she entirely breastfeeds, total amount of time period for which.
What is the significance of that?
Sir, exclusive breastfeeding it reduces the risk for developing breast cancers.
No, but why does breastfeeding, see, cumulative or not, if a lady has breastfed during the period of breastfeeding, what benefit does she acquire, which, retards incidence of breast cancer? What happens?
Ma'am, it decreases cycles are estrogen exposure will be reduced during that period of breastfeeding.
So there is reduced exposure to estrogen. So whether it is, 3 separately or cumulative, as you said, because this is the first time I'm hearing that cumulative thing, it is usually, that is why you take a history of, number of pregnancies and how long she breastfed, because each episode when she's either pregnant or she's in the lactational amenorrhea, her estrogen levels are low. So she is supposedly protected from the incidence of chances of getting breast cancer. So cumulative breastfeeding, I'm not so sure, I've not heard of it, but yes, the other teachers can also comment on it. So I think it would be best to say how many pregnancies she had and whether she breastfed them for what duration, because that is the period when she's protected from breast cancer.
Yes, sir.
Okay.
Mala, can you tell that what is the incidence of triple negative breast cancer in Indian scenario as compared to the West? Is it high or low? It is high. No? In Indian scenario, almost about 30% of the patients, they are triple negative. While in West situation, it is much lower. Okay. Now, can you tell
having said that, Dr. Khanna, you also kind of need to understand, because Indian women are getting it at a much younger age group.
That's right.
So the overall, if you are looking at overall, incidences of, yes, triple negative is heading this thing. But if you again convert Indian women into post-menopausal and premenopausal, the ER/PR positivity is equivalent to the Western counterparts in the post-menopausal age group.
No,
Overall, yeah, we are getting, but in a post-menopausal, it is still ER/PR positives that we see, typically as it's mentioned in the textbooks.
Yeah, we know that Indian women are younger for the
Yeah.
breast cancer, but even in those younger age groups, if you look at the triple negative breast cancer which are there, it is quite high.
Yeah, it is very high. Yes,
Yes,
yes, yeah.
Taking off from what Dr. Shilpa said, see, your lady who is a 65-year-old, do you think there is a higher probability of being triple negative or otherwise? So older women with breast cancer have been seen to be more triple negative. Okay. So that is, so because it was brought up, I was thinking of taking up this when we come to management, but yes, since it has been brought up, I just thought I'll complete that. Older women with breast cancer are more commonly triple negative than otherwise.
Yes, sir.
Yeah.
Bala, can you tell what are the things you asked about the risk factor in your family, in the history?
Sir, whether her mother or sisters or daughters, anyone had any breast lump which they were operated for, or any cancer-related deaths in the family?
Right.
Any colonic malignancies?
Okay.
History-wise, anything?
Yeah.
How do you
So
differentiate?
tell me what are the various absolute risk factors for the breast cancer? Absolute.
Sir, absolute risk factor is sex, sir, females, age of the patient, and any genetic mutations, sir, hereditary mutations.
Okay.
And
BRCA1, 2 positive. Okay.
BRCA1, 2.
Okay. What
and
else?
if the patient is, she is diagnosed with the breast cancer, like proven malignancy.
Yeah. Good. Or the opposite breast.
Of the opposite breast. And,
Yes. And in the family history, isn't it?
in families.
And in the family history, what are the specific things you're going to ask in the family history according to the risk factors which are there?
Sir, if the risk factors at the family history, what was the age the member was identified with the breast CA?
Yes.
And what was the prognosis of the how it turned out, whether she was operated or what type of cancer it was, and what is the prognosis, sir? How she is?
Another very important thing is whether it was the unilateral breast cancer or the bilateral breast cancer.
Yes, sir.
So the two most important thing is the age of the patient, means premenopausal or postmenopausal, and second is the unilaterality or the bilaterality. So if somebody the premenopausal in the family had the breast cancer and it was on the bilateral side, there is a maximum risk is there.
Yes, sir.
Okay, right.
Yes, sir.
Now another thing, Bala, can you tell that how much time does it take to get 1 centimeter palpable breast lump?
Sir, it takes almost 4 to 5 years, sir.
Okay. So what is the tumor doubling time?
The tumor doubling time is 28 cycles, sir.
No, tumor doubling time. For the breast cancer, what is the tumor doubling time? It's around 100 days. 100 days, okay. So that takes around 5 years to complete 30 multiplications here. And 30 multiplication will take about 5 years. And when the metastasis can occur from the breast cancer, if you look at this multiplication.
Sir, if it is more than 2 centimeter.
No, metastasis can occur even at 22nd or 23rd multiplication day. So even if it becomes, it's a smaller tumor than the 1 centimeter, subcentimeter size, still it can metastasize. And that is the Fisher concept. You know Fisher concept?
Yes, sir. It is a systemic disease from the start. And
what is the Hallstadian concept? What is the Hallstadian concept and what is the Fisher concept?
Sir, Fisher concept is that it is to start with it is a systemic disease. It can have metastasis even before locoregional spread.
Right.
But in Hallstatt Halittus comes once the locoregional spread is established. After that, systemic.
It's a locoregional spread is there. Okay.
spread,
Yeah. That is why he described about the radical mastectomy.
Yes, sir.
Okay. But nowadays, which concept is acceptable? Both are not correct.
Correct. Yes, sir.
Or both are correct. That is called the spectrum concept. Okay, where it can be a systemic disease and also the locoregional disease. And that is why you always use a combination treatment. Majority of the time you will use the combination treatment for the breast cancer.
Yes, sir.
Okay. Yeah, you can go on the examination now. Yeah.
Shall I proceed to examination, sir?
Yeah, go on the examination.
Yes, sir. Yes, sir. General physical examination. The patient is moderately built and well-nourished. She is oriented to time, place, and person. Pulse is 80 beats per minute in right radial artery. Normal rhythm, rate, rhythm, volume, character. Blood pressure is on 10/80 in right upper limb in supine position. Respiratory rate is 16 cycles per minute. She is afebrile. No pallor, icterus, cyanosis, clubbing, periodema, or generalized lymphadenopathy. ECOG score is 1. Local examination. The patient was examined after taking consent in presence of a female attender with adequate exposure and in a well-lit room. She was examined with keeping her hands by the side, hands raised above the head, hands at her waist, in leaning forwards and in this, recommend positions. Inspection. Sir, I'll show the picture once, sir. Or...
Yeah, just remove that. Yeah. Okay. Yeah.
Yes, yes,
Just remove the picture now.
Yes, sir. On inspection, there is a fullness noted in the right breast, more in the inner quadrants, with dilated veins over the quadrant. The right nipple appears retracted. No pudgy orange nipple discharge are also over the right breast. On raising the hand above head, there is indrawing of the right nipple. On falling forwards, left nipple is at a lower level than the right nipple. Coming to palpation, a single lump of 15 cross 12 centimeters in the right breast, which is non-tender, and there is no local rise of temperature, predominantly occupying the upper inner and lower inner quadrants, with the nose with margins well defined and hardened consistency. The lump, the skin over the lump is pinchable. The lump is not restricted and it is freely mobile on putting the pectoralis major muscle into contraction. There are no palpable axillary or supraclavicular nodes. Other systems examination: abdomen soft, non-tender, no organomegaly, hernial orifice is free. Respiratory system: bilateral normal vesicular breath sounds. CVS S1 S2 heard, no added sounds. CNS, no focal neurological deficit. Summary: a 65 years old postmenopausal lady presented to the OPD with complaints of lump in the right breast, which was initially small in size and reached the present size of about 15 cross 12 centimeters in 2 months, with no history suggestive of metastasis. On palpation, there is a 15 cross 12 lump occupying the inner, upper inner and lower inner quadrants, with in the retroareolar region, with there is a slight retraction of the right nipple. The surface is the lump is mobile, borders are well made out, nodular surface, and it is hardened consistency. With this, I would like to give a provisional diagnosis of probably phylloid tumors.
Okay, Bala, can you go back to your first local examination slide, please? Yeah. So you have said that you're favoring a diagnosis of phylloids, right? So what are your features from your inspection which favors a diagnosis of a phylloids? Because you had given a differential of a carcinoma and a phylloids after your history. Right.
Yes, sir. Ma'am, on inspection, there is fullness in the upper inner and inner quadrants, ma'am, and the skin appears stretched, and there is a dilated vein, but it is not that much.
Okay, you don't have to show the images. You can just talk.
Yes,
yeah.
Yes, sir. And there was dilated veins over the on top of the lump, and there is no pudgy orange. There is no puckering or dimpling of the skin, and on falling forwards, the breast falls equally freely, signifying there's no attachment.
I asked you, what are your findings which favor the diagnosis of a phylloids? Not all your findings, okay? What are your findings which favor the diagnosis of a phylloids?
Ma'am, on inspection also, the surface appears bosselated, but
that is what I wanted. So the surface appears bosselated.
Bosselated.
And one more
and
thing.
There are visible dilated veins over the...
Yes, so these are the two things on inspection. right?
Okay, so
Okay.
can I also ask him what are the 2 factors which are against a phylloids in this inspection?
Right, yeah.
Ma'am, there is a nipple retraction which is against the phylloids, ma'am.
So what happens classically in a phylloids with the nipple?
Ma'am, classically the nipple will be displaced outwards, ma'am.
Yes, so in a phylloids, the nipple is pushed away from the tumor,
Out.
while in a malignancy, in a cancer, it is pulled towards the tumor.
Towards the tumor.
So when you say that it is an indrawing of the nipple, that is where it doesn't match. That is where it doesn't match. Usually it is free from the underlying tumor. Anything else? Can you go on to your next slide, please? Yeah. Yes.
What
Ma'am,
are
in
the
this,
other skin signs you're supposed to see there on inspection?
So,
On the skin.
ma'am, what, ma'am?
Changes in the skin. On inspection, what are the things you need to see?
Ma'am, in general, ma'am, or in this case?
No, in this case, on the
In
skin
this-
surface.
Ma'am, if there are dilated veins or this,
Okay. But anyhow, you want to rule out a malignancy. If it's going to be a locally advanced lesion, in that case, what are the other skin changes you're supposed to look for?
ma'am, I'm supposed to look for pudgy orange, ma'am. If there is any dimpling or puckering of skin, any ulceration,
Dimpling, puckering doesn't come under skin changes.
pudgy orange.
Purity orange, then
If any ulcer is there, a nipple
Okay.
discharge,
discharge doesn't come under skin change.
no.
It is, you need to look for what? Edema, that is purity
Edema.
orange, ulceration, and satellite nodules.
Satellite
You mentioned
nodules.
about satellite nodules, right?
Yes, ma'am.
So what do you mean by satellite nodules?
Satellite nodules from the lump which is situated within 2 centimeters skin. It is a cutaneous deposit, ma'am.
So it's a deposit which is occurring over the skin, and that should be a normal bridge of skin between the primary
Skin
and
between them.
nodule.
The
Okay.
nodule.
So that is satellite nodule.
Yes, ma'am.
Okay. So that was not there in your inspective findings.
In-
Right. Go ahead.
Yes, ma'am.
Another skin change that you have to keep in mind is a brawny edema. There's that leather-like look. But yes, that is often in the case of, post-mastectomy changes. But when they tell you what are the evidences of skin involvement, that will also come in addition to what Madam has just said, right?
Yes, ma'am.
Why do you get a purity orange?
Ma'am, it is due to obstruction. The tumor cells, it will obstruct the lymphatic flow, and due to retrograde obstruction, there will be pudgy orange.
So any lymphatic or some specific lymphatic obstruction?
Accelerating
No,
nodal.
it is the subdermal lymphatics which get blocked to give you the pudgy orange. It's not the axillary here. So the subdermal lymphatics, they get blocked by tumor cells and then giving rise to the pudgy orange appearance.
Yes, ma'am.
Can you get a purity orange appearance apart from malignancy in any other case?
Yes, ma'am. Even in the infected cases, we can get pudgy orange.
In that
Breast
case,
abscess.
how does it happen?
Ma'am,
So
it
usually
might
the
be due-
breast abscess, the nodal disease, the lymphatic basin might be blocked. So that
yes,
might
ma'am.
be
Due
an
to that,
edema which is happening in the subcuticular plane, wherein your hair follicles will be standing prominent.
Okay.
But in malignant CA breast, usually the
Pudgy.
subdermal lymphatics are being infiltrated by your malignant
Yes, ma'am.
cells and they tend
Yes.
to get blocked. Okay,
Yes, ma'am.
go ahead.
Okay, so your features favoring phylloids is number one, the large size, the bosselated
Large size.
appearance, the dilated veins. There is mobility of the lump over the pecs. But the only thing which is going against it, and the skin is free.
Skin is
And the
free.
only thing which is going against is the nipple, right?
Nipple retraction.
And you've said that there are no palpable axillary or supraclavicular nodes.
Nodes.
Okay.
Yes, ma'am.
So how would you like to?
There's a question, I think, in the audience about the role of diet in patients with breast cancer. Do you know what are the protective diets?
Sorry,
You know,
no idea.
Yeah, like what is phytoestrogen? What are diets which help this thing? What is the specific diet which Asians used to eat a lot and which is now kind of changed over, which is why Asians are having a higher incidence? What food exact is protective? Like routinely available food?
Ma'am, So, I'm sorry, I have no idea.
Yeah, so soy is supposed to be, but there is a lot of study on soy. So soy, essentially, soya beans we're talking about. If it's taken from early, like from the very beginning, okay, since childhood and teenage and this thing, it's supposed to be protective. As you grow older, its protective effect becomes lesser and lesser. I mean, it is still protective, but not as much. And so that's why, so phytoestrogens are considered protective for breast cancer. So
Yes,
that's something you should know about isoflavones and phytoestrogens. Yeah,
Yes, sir.
go on.
One more doubt regarding your presentation. In inspection, you said
Yes, ma'am.
the left nipple is at a lower level than the right.
Ma'am, on falling forwards.
Yeah. So what happened? Why is the right nipple is not falling forward down? Is there any fixity there? But you said it's freely mobile on
Yes, ma'am,
palpation.
but there is a retraction. Right nipple is little retracted. It is retracted. Right nipple is retracted.
But from your image, it doesn't look that much retracted.
Yeah, this
When I
one.
saw it, right? Take the image out.
Yes, ma'am.
See, when you have a huge mass, especially with the heavy weight, definitely that should fall forward a little more down rather than compared to the
Prominently,
normal
the
side.
normal side.
Right.
Yes, ma'am. Yes, ma'am.
Definitely there is a asymmetry in the breast, but still you say that it only falls forward. In that case,
Yes, ma'am.
is there any fixity to the posterior wall, the chest wall?
No, ma'am, it is not fixed. No, it is free, ma'am.
Okay, fine, go ahead.
Ma'am, I can
Yeah.
go to for
Yes,
management.
please. Yeah, please carry on.
I-
So
Can
you
you
now
just
come
show
to
me
the
your
sum-
diagnosis? I'm sorry, I'm interrupting, but
It's
can you
okay.
just show me your diagnosis once before?
Yes,
So
ma'am.
you are, after your clinical entire exam, you want to completely rule out a malignancy in this woman?
No, ma'am, I would like to evaluate her and then I would like to give a
No. So I think you cannot rule out a malignancy.
malignancy
It
in this.
should be your differential, irrespective, because of all the factors that you have to rule out a malignancy. I mean, in a 65-year-old lady, the first line of management would be to rule out a malignancy. So you can't not put it in your provisional diagnosis.
Yes,
Yeah.
Yes, so I would
Yes, ma'am.
like that you keep it as a differential only, instead of,
Yes, ma'am.
going bang on to phylloids. Okay, so that's, sir, I would like to give a differential because there are features favoring each of them in clinical examination, right?
Madam, just one or two questions. Balakumar.
Good evening, sir. Yes, sir. Good evening, sir.
Good evening. Just inspection, just quickly put that slide. I won't take much time. Please, no, slide.
Yes, sir.
Just one question to you. Why you raise the hand above the head? What is the
Sir, it will,
actual?
if any,
Yes.
if nipple retraction is there, it will be more prominent, and if skin puckering is there, it will become more prominent.
So what actually happens when you raise the hand? Actually, what really happens? When you raise the hand, basically you would like to see the inferior quadrant of the tube.
Yes, sir.
Yes, some pectoral also gets pulled. So some beauty oil, if it is there, skin and other breast also moves. Second thing is, I would like to ask you one question. You have not mentioned anything about the axillary fullness as well as supraclavicular fullness and edema of the arm. See, when you do the inspection, these are the important things. When you raise the hand, you will also get a chance to look into the axilla.
Axilla. Yes, sir.
Edema of the arm, such a large tumor with whatever dilated veins which you have told. Okay, so that next, can you quickly go to that systemic examination? Yeah, just see that. I don't know whether I have missed. You have not mentioned skeletal system. Have you mentioned?
No, I forgot, sir. Yeah.
No. There is
Fine,
such a large tumor. Who is? We are not interested in. Not that you don't bother about CVS, CNS, but it is very important.
Final. Yes, sir.
Because that also alters your clinical staging also. And, What is that skeletal system you would like to examine here?
Sir, vertebral column should be surveyed. Spinal survey.
Function. What did you tell? What?
Vertebral tenderness.
Tenderness, sir.
Tenderness.
Paraspinal tenderness.
So what is the difference in TB spine and here when you examine for tenderness? You know, one of the common diseases, you know, that whenever you do the general physical examination, you mentioned no pedal edema, no spinal tenderness. Once TB was rampant, so that is over the spine, collapse, gibbous. Here, what is that? Paravertebral means what?
Tenderness.
No, what
Sir,
is that? What is that you will do? How
sir,
do you?
we'll palpate along. We'll palpate along the transverse process of the vertebra to see for tenderness.
So it's a little bit of turning moments, you know, with the thumb we should examine. Okay. So you need to clearly mention in the clinical examination, especially thoracolumbar region. Okay, lower thoracic and the lumbar. So, and again, you cannot straight away tell skeletal system normal. Abdominal, no hepatosplenomegaly. See, especially a case like this. Be specific. You will no organomegaly, yes, but correct ascites. We can't take it for granted. If you have written soft non-tender hernial orifice, who is it? Not that we are not in hernial orifice. But what is important? What is important to look for? Yes, hepatomegaly, ascites. So that is what is more important. Okay. So be specific because and when you give the diagnosis, just go there. Explain, I think. Next one. Yeah.
Okay. So one more comment on this, since we are on the this thing of metastasis. Why did you ask for CNS metastasis? Which kind of tumors usually metastasize to the CNS?
Ma'am, with hematogenous.
Which kind of?
Which type?
What IHC status? Would you look for active CNS metastasis? On the
K67 and P50.
no, no. These are the HER2 positives.
Okay.
The HER2 positives metastasize to the choroidal plexus of the orbit of the eye and to the CNS. So if you're saying that there is no CNS metastasis, you should know why you're asking it. Yeah.
Yes, sir. Yes, sir.
Yeah. Please continue.
What are the various other things you look in the abdomen in a patient with cancer breast?
Sir, first,
hepatomegaly and the ascites. What other things can be there?
In premenopausal, okay. Sir wanted that.
Will you consider doing an internal examination?
PV and PR to look for a blummer shelf, and if a ovarian tumor is there, we have to check it.
So this ovarian tumor which is there, what is the name of that? What is the name of that tumor?
Sir, Krukenberg's tumor.
Okay, so what is the characteristic of this Krukenberg tumor? Is it unilateral or bilateral?
The bilateral.
Bilateral. Is it solid or cystic? Okay, it is solid.
Solid.
Okay. Majority occurs in the premenopausal, but can also occur in the postmenopausal also.
Yes, sir.
Okay. It was always thought it is a transgenomic spread which is there, but now the concept of the retrograde spread which is there. So even in the postmenopausal, sometimes you can get the Krukenberg tumor. But majority of that is the premenopausal one.
Yes, sir.
Can you get a Sister Joseph nodule in CA breast? You know
Where
what
do
is
you get the Sister Joseph? Yeah, where do you get the Sister Joseph?
Usually in CA stomach carcinoma will get.
Yeah, but where do you get that nodule? Which part
Umbilical.
of the body? Umbilical nodule.
So it can occur also in the CA breast, especially if it is a tumor of the lower inner quadrant.
Yes, sir.
Okay, through the falciform ligament, it can go here and it can deposit at the umbilicus.
Yes, sir.
Okay.
How much percentage is, it's a very high percentage. How much percentage of these breast cancers can metastasize to the ovary?
Sorry, madam.
Up to 30, almost 30%. And in addition, you could also have a primary ovarian tumor, especially in hereditary, which is there in Indians to a large extent. So it is imperative that you mention all the three things, the ovaries, the ascites, and the liver. All three should be mentioned. The incidence is almost 30% in each aspect of it. Yeah. And there's also something known as a pseudomixed tumor, which is like a myxomatous lesions. So it can present as a Krukenberg's or a pseudomixed lesion, but both have high percentages. So you can't miss ovarian.
Yes, sir.
Yeah.
I think, Bala, you move on with your plan for the patient because you just have 15 minutes more to go. Yeah.
Yes, sir.
So how would you like to
I would-
proceed with this patient?
I would like to confirm my diagnosis and evaluate the patient as a part of a triple examination, clinical examination is over. Next, I would like to get the imaging, ultrasound of the breast, and following ultrasound of the breast, like for a FNAC of the lump.
Hold on. So as she's 65 years old, just an ultrasound will be adequate, or would you like to add something more to that? What sort of a breast are you expecting in a 65-year-old?
Ma'am, fatty breast.
No, just a reverse. No, just a reverse. It won't be a dense breast. It is going to be a lax breast, right? So just an ultrasound, or would you like to combine it with a mammogram? It will be a sonomammography.
Sonomammography. Yes.
Sonomammography. Okay.
You have a choice between the ultrasound and the mammo. In this 65 years female, what is your choice?
Sir, ultrasound will be easily available everywhere, but
No, I'm asking choice, not the easily available thing. Everything is available to you. Yeah, mammography.
Mammography.
Okay, it's not a dense breast at that time, Yes, and that is why you can do a mammography. Mammography gives much more clear picture for the malignancy.
Sometimes the radiologists like to corroborate it with the sono findings, but yes, at this age, definitely a mammo will give you a lot of information. Next, for tissue diagnosis, you said FNA. Sorry, but now I do not agree with that. Would you really think of an FNA, or would you think of something different?
True biopsy.
Absolutely. It's a core needle biopsy. Don't use brand names. Use a core needle biopsy. So why did I oppose the FNA so much? I mean, I grew up doing an FNA, but I'm asking you to go for a core needle. So what benefit do you get in a core needle as opposed to an FNA?
Ma'am, we can see whether it is an invasive or in situ carcinoma, and we can look for receptor status also, and we can plan the management accordingly.
So basically,
Bala,
see, in FNA, sorry, yes, Shilpa.
No, please continue, and I'll wait till you finish and then I'll ask.
Yeah, thanks. See, FNA is nothing but cytology. Remember that, okay? Where core needle, you are getting a histology. So you're getting a core of tissue. So yes, you will get information on not only the type, you will get information on the grade, you will information on whether there is breach of the basement membrane. You might get some information on, perineural invasion, but that is not so much. But most importantly, receptors. We've been talking so much about triple negative and all that. So in 2023, you cannot just get away with an FNA. And definitely you cannot plan a mutilative surgery like a mastectomy or something on the basis of an FNA. So yes, your first point will always be a core needle biopsy. You might opt for an image guided, but such a huge lump, not necessary. But if you have a bosselated appearance with a variegated feel where there are regions of cystic and solid components, there you might want an image guided. But otherwise, a core needle should be your target tissue diagnosis. So imaging will be mammography plus minus sonography. Tissue diagnosis is going to be core needle biopsy. That is going to complete your triple assessment. Shilpa, you wanted to say something.
No, yeah. So in fact, for a phylloids, even more than a cancer, you need a core biopsy. Phylloids cannot be diagnosed on an FNAC. So irrespective, I agree with you completely. I think you shouldn't mention an FNA at all for a breast lesion unless it's a it's multiple fibroadenomas, and even there you can get.
Hello.
Dr. Shilpa said that particularly in phylloids, which other condition of in a breast can mimic a phylloids? Where, we usually get away with an FNA. Or rather, I'll rephrase my question. If an FNA can misdiagnose a phylloids for something else, because their pathological features are very similar.
Sarcoma,
phylloids is a sarcomatous. It's a giant fibroadenoma. A giant fibroadenoma very often, or rather a phylloids mimics a giant fibroadenoma and the other way around. So if you just do an FNA and they tell you it's a giant fibroadenoma, you might, take the treatment along the wrong way. So yes, a core needle has to be, as Dr. Shilpa said, do not mention FNA in your exam because unnecessarily there'll be too many questions which you don't want. Okay, so go for core needle straight away, and that is easily available now. So there's no reason to say that it's not available. So having completed your, so you did a core needle. This is your FNA report.
FNAC, yes, FNAC.
Okay. Proliferative breast disease with minimal ATP.
One more question. On a mammography in this lady, if you're suspecting a phylloids or you're suspecting what is the classical sign that you get on a mammography for a phylloids?
Well circumscribed lesion with.
But even a giant fibroadenoma, many other things can happen. There's a very classical sign for phylloids. So there is a halo which is seen. There's a halo which can be seen along with macrocalcifications, along with a well-defined mass. There'll be a halo. So that is very typical of a phylloid tumor. Yeah. So mammography helps, and ultrasound. I would do a biopsy of this lady under ultrasound guidance because if it's a phylloids, it tends to be very, very vascular. And, we've had instances where we do it in the minor OT and patient comes with a huge hematoma the next day. So in a large tumor with a lot of veins, better to do it. And ASCO guidelines also say that it is better to do it with a image guided. Okay. Yeah.
Another thing, talking about the imaging, remember, even with a mammo or a sono, often we cannot differentiate between a giant fibroadenoma and a phylloids. They have very similar appearance because they might have bosselated appearance. You might have fibroadenomas also which have bosselated appearance. So ultimately, it will be your core needle which will lead you to your next step of management. Okay. So I don't think you did a core needle. You've done an FNA here, which says that there is no evidence of malignancy and proliferative breast disease with minimal ATPR. So what would you like to do next? So it's somewhere you're stuck, isn't it, with this report? So what would you like to do next then?
Next core needle would.
Yes, you would have to see. So this is what happens. It doesn't take you much further. Sometimes we have in FNAC saying invasive ductal carcinoma. You may be happy, but that information is not adequate. So you ultimately have to do a core needle. So did you do a core needle in this patient?
No, not yet.
You did. So as you have done, if you have not done a core needle, how will you manage this patient? What would be your plan?
Considering that it is a phylloids tumor, wide local excision with the 1 centimeter margin and marking the tissue cavity.
But it doesn't say it is a phylloids here.
Exactly. It's not a phylloids.
It doesn't say. Your report doesn't
and there is
say.
atypia. So
Yes.
there is atypia, which is not seen in a phylloids. So why are you stuck on phylloids as your diagnosis?
So if this patient came to me in my clinic with this report, I would definitely send her back to get a core needle biopsy. That is for beginning, okay? And depending on the core needle biopsy, I'm going to move forward. I'm not going to jump on, see, this minimal ATPR could take me a lot of places. So I will not plan my decision as per this FNA. So I'll put two scenarios in front of you. Number one, since you had two DDs in mind, number one, that you have a core needle with SAYS and invasive ductal carcinoma with triple negative. That is one scenario. And you have a second scenario which says it is a phylloids tumor. Now take two cases, right? So what will be your planning for the first case and what will be your planning for the second case? The same lady, clinically the same, but you have, I mean, if you have two scenarios, how would you plan for the first case where the core needle says it's an invasive ductal carcinoma of, say, grade 2 with triple negative?
Shamanta, I would still make a point here. Minimal atypia not seen usually in phylloids, and if I have a patient who is having a large area of tumor mass which is query, I would advise an MRI in addition to all of this, because I do not want to miss an area which is likely malignant, especially with the fact that there is, on an FNA minimal atypia. So I think the next thing I would do would be an MRI, and then, and then a biopsy, and then, yes, and then we have your scenarios. But I think that would be my opinion on this.
Yeah, but the only thing is that MRI again is not very sensitive of phylloids. Yeah, so if the minimal
Not, but at least it will rule out a malignancy for sure. Yeah.
Right, true. Agreed.
Yeah. Go on, Bala. Answer her questions.
So I've given you two scenarios. Let's take the first scenario first. The malignancy. How would you like to plan now?
Ma'am, if it is malignancy, I would like to evaluate the patient still more. With this size, I like to get a CT thorax and CT abdomen.
So the term will be, as an MS candidate, you have to use precise words. Sir, I'm going to do a metastatic workup for this patient. Metastatic workup for this patient. And what will be the components of your metastatic workup?
Ma'am, in metastatic workup,
you said CT thorax, what else?
Thorax, CT abdomen, ma'am.
And?
Abdomen and pelvis. And brain, CT brain also should be done. Since
you finish, then I'll correct you. And so the basic metastatic workup should have a thorax, abdomen, and a bone scan. A brain CT is not for all patients unless the patient has features suggestive of brain mets. Okay. So the obvious question that will come up next is, can I not do a PET scan? That is, everything goes in one go, isn't it?
Yes, ma'am.
So yes, as the PET has not yet come into the NCCN guidelines, but probably it will very soon. Number one, the availability is a factor. Okay. Yes, it has the advantage of, all of the areas getting scanned together. The cost is another factor. But I think for an, MS or DNB exam, if you say I do a CT thorax, a CT abdomen, and a bone scan, and definitely an LFT, that should complete you for the exam purpose. Okay. So PET CT is a debatable topic. You will be pulled into it and you should tackle it smartly. Okay. So you've done a metastatic workup and there is no evidence of any distant metastasis. So basically she's what? She is how would you stage the disease then?
It will be T4.
T4 what? A, B, C. T4 again has subdivisions.
Subdivisions.
Yeah.
T4A.
T4A. Why do you say T4A?
No, it is not fixed to chest wall.
Okay. So fixity to chest wall would make it what? Fixity to chest wall would make it what?
Got confused.
Yes.
T4A is what? Involvement of the chest wall. T4B is involvement of the skin. C is combined.
Combined.
So A is chest wall, B is skin. So there was, ma'am had asked you a question that what are the evidences of skin involvement?
Skin.
So
Yes,
nipple retraction, was it an evidence of skin involvement?
Yes.
Yes, sir.
Yes.
Beauty orange is the most.
Beauty orange. Yes. Yeah. So if your patient had beauty orange, then it would be 4B. Okay.
Yes.
Just nipple retraction will not make it. So it is a T4B. What was your N?
N0.
N0. And after you've done the metastatic workup, it is M0. So 4B, N0, M0. So how would you class it? Is it an early breast, locally advanced? How would you classify this now?
Samita, this patient doesn't have any skin, this patient doesn't have any skin involvement, right?
If there is no skin involvement, it won't be 4, it would be 3.
Yeah, so that's why.
So he said there's beauty around.
Yeah.
So if there's
Yeah,
No.
no,
He
there
was
isn't.
answering
So
that
in
it
this
is skin
patient,
involved findings.
it's not going to be T4. What will it be,
Then it
Bala?
will be- Then what will it be?
More than 5 centimeters, T3.
So it's
T3,
T3,
yes.
T3, N0, M0, right? Now
So
tell
what
us
does
the
it make
management.
it? What does it make it? Is it an EBC? Is it an LABC? What is it?
What stage does it come under? Stage 1, 2, 3, like that.
See, we very
It is
commonly
an L-
encounter the early breast cancer and the locally advanced. There is something also which we don't use so frequently. It is called a large operable breast cancer, right? So large operable meaning what? Size-wise, it is big, but as you said, it is an N0. So locally advanced means there has to be involvement of axillary lymph nodes. So yes, sorry.
Skin, nothing of cutting.
Yeah. So since there is no axillary lymph node, it's an T3, N0, M0. You can also call it a large operable breast cancer. Okay. Large LA, locally advanced breast cancer, would be when if you had, suppose a T3 N1, okay, or a T4 A and B with N1. That is going to be LABC. Early breast cancer, obviously, are much smaller lesions. Okay. So how would you like to, what will be your plan for this patient? See, we still have to discuss phylloid, so let's move a little faster.
No, sir.
Yes,
Single line,
Mastectomy.
just one line.
one
plan.
liner answer. Yes.
Mastectomy.
No. Such
So
a
see,
large tumor.
yeah,
Your
you should
judgment
always
and-
say, I would like to
Hey.
discuss the options with the patient. That is how your answer goes. You're going to be a consultant soon. So I would like to discuss the options, and the options are twofold. Whether
Balakumar,
conservative is
madam
at all
said
advisable or
receptor
not, that
status
has to be
was-
discussed. Sorry, madam.
receptor-
Yes, miss.
The receptor status which was given was triple negative. Remember that?
Yes, ma'am. Yes,
Ah.
yes. Triple negative. Yeah.
Now think over and tell what is your management.
Mhm. What is the best option for a triple negative? Very sensitive to what? Triple negatives are very sensitive to?
Chemotherapy.
Yes.
Yeah.
Yes,
So what is
that's
that called? That is so, in fact, the standard guidelines mention that any tumor which is more than 5 centimeters ideally should undergo an NACT,
Yes.
triple negative or
Yeah,
otherwise, even more so in a triple negative
In a
case,
triple
because you can't
negative,
give
yes.
them anything else,
Yes, sir.
right? So what NACT would you give her?
Adriamycin and anthracycline based.
Only anthracycline based? Which are the other ones? For triple
Taxane.
negative, Taxane is another one. And if she was a younger woman, what would you give her in addition? You would also consider carboplat in a younger lady who is triple negative. But you want to give them the whole, possible things that you can give on chemo, because that's the only thing that it really responds, right?
Yes,
They have a very poor 5-year survival. So give them the full NACT. Then you would like to do?
Reevaluate the status now, whether it has response to the chemo.
So excellent response. Do you know the resist? Do you know the criteria? Do you know the
Resist
scoring
criteria.
system, the resist criteria? What is it?
Response evaluation criteria in solid tumors. If it is
Okay, I think we are running out of time. So just tell us, the tumor has become PCR, but it's like clinically not palpable now. Now what will you do? See, consider her age, consider her status. What would you advise her?
mastectomy.
No, say the full form. No, you'll do only mastectomy. You will not do a nodal clearance.
Modified radical mastectomy.
Okay.
But lymph nodes are not involved. So with the
See, even if lymph nodes were not involved, just a simple mastectomy is not an option. Okay, so you had clinically said it was N0. Even if it was N0, I would like to, evaluate the axilla once again. It could be radiologically N1. If it was also radiologically N0, there is always an option of a sentinel lymph node biopsy. So don't say that just because it is N0, I'm not going to address the axilla. Axilla has to be addressed, okay? So if you can again discuss the plan. She's 65 doesn't mean that you sign her off. She may opt for other surgeries as well. But as Dr. Shilpa said, if it is a complete pathological response, we are in a dilemma. When you are giving the chemo, because now the dictum is you give all the chemos upfront if she's responding. If you see that, the mass is regressing very fast, then this is the point where you have to go in and put a marker in the tumor. Otherwise, if there is a total at least a clinical and radiological response, you have no way of knowing where the tumor was. If you have a marker, you can take out that, the marker, a core of tissue with the marker at its center. But yes, if it is a complete pathological response, as ma'am said, then it's an open debate. You can either debate in favor of observing her, or you can debate in favor of, taking out the whole breast, So that's an open debate. So as postgraduate residents will pull you into debates at every opportunity. Okay. So complete pathological response is a very tricky situation. But to prove a complete pathological response, again, you have to have an image-guided tissue diagnosis. Because there is no way of proving a pathological response, complete pathological, till you have proven it with a tissue diagnosis. So that becomes very tricky. So if you see your patient is responding well to chemo, put a marker. Some centers, they believe in putting a marker up front at the beginning of NACT. Others feel that you don't need to do it for every patient. If you see there is a good response, you put in after the second or third cycle. And so that if there is a regression, you can, do a conservative breast surgery. Dr. Kanaga will please tell us whenever we need to stop. Otherwise, we can just go on with this.
No, but I think it is better for them as postgrads to say that they put in a marker upfront, because that's again what the guidelines suggest. And I think for an exam, just finished an MS exam today. So, I think guidelines will help you better your arguments. So what's in the guidelines is to put in a marker at the beginning of the NACT. So stick to that thing so you won't have any confusion. Okay, last thing, will you give her radiation or not?
Ma'am, in case of if phylloids,
No, Raja, now we are still discussing the TNBC, LOBC. Will you give her radiation or not after you do your MRM or sentinel node?
Rather, what will be the indications of radiation in this case?
One word answer.
If breast conservation surgery is planned,
no. You've done a mastectomy.
What is the indication for RT post mastectomy?
Ma'am, if actually no dissection was not done.
No. See, you have to again, divide your answer into two groups. Number one, if I have done a breast conservation surgery, every patient will undergo radiation. Okay, that is one group. The second group, if I have done a modified radical mastectomy, if there is a deep margin positivity, I need to irradiate the chest. As far as the axilla is concerned, if there are more than 4 nodes positive, or if there is an extranodal extension, then you need to irradiate. Okay, so this is the basic. There is a very small subgroup of patients with small tumors and other things who do not need it. But most of them, these are the conditions where you have to irradiate the patient.
So anything more than 5 centimeters, irrespective, you'll irradiate.
Yes.
So in this lady, there is no question. You will irradiate her post. Yeah. I think we'll move on to phylloids. Let him complete that. And I think we can get out.
Shilpa, Dr. Kanagavel has left a note that we need to move on to the next case in the first place.
So let him just say one sentence on phylloids. What is his management? And we'll shut it off.
1 second for radiotherapy. Remember the 0.345. Grade 3 tumors, 4 nodes, and 5 centimeter tumor. These are absolute indications for radiotherapy.
And that's very nice.
Apart from that, all this lymphovascular invasion and other things need to be added on. Right? But these 3 points are mandatory.
Yeah, very simple to remember. Phylloids, one line treatment plan.
Wide local excision with marking the margin, and after that, if after a biopsy report, if the margins are free, I think, ma'am, if margins are still involved, revision surgery should be planned.
First things first, whether the histopath is a benign phylloids or a malignant phylloids. That is going to make all the. Will you do an axilla in this case, in a phylloids?
No, ma'am.
You
No
don't
axilla.
do the axilla because the commonest spread is a hematogenous spread.
Right.
Commonest center for metastasis in a phylloids, malignant phylloids?
Lungs, sir.
Lungs, exactly. So you usually do a simple mastectomy, what you were thinking about, if the tumor is too large, otherwise a wide local excision with the margin that you talked about.
Yeah, Dr. Kanagaral, we are done, I think. You can take over.
Madam, thank you very much. I think Rajgopal sir and Kanna sir have come and I think they have something to say with those words, and then we will take it further now.
But I just want to know, if you go for a breast conservation surgery in this patient, how do you label the specimen?
Ah, yes.
Sir,
Because the
Something small.
pathologist has to know that
yes,
which margin is positive or negative.
first,
Something long, something short.
long,
Do
yes,
you
sir.
remember that?
Yes, sir.
See, it is a very simple way to remember. A long lateral, mean the lateral part of the specimen will have a long suture, short superiors. That means SS, okay? And yes, if you've done a mastectomy, it's very easy because the skin paddle will tell you that is the superficial surface. But if it is a lumpectomy that you've done, then the deep surface should have two sutures, double deep. So long lateral, short superior, double deep. Two sutures in. I think you got confused. Double meaning, deep meaning that if you've done a lumpectomy without a paddle of skin. So you have to also identify which is the superficial surface, which is the deeper surface. So you should have two sutures at the deep. So LL, SS, and DD. That is how you have to remember. And how would you define that a margin is negative? What is a negative margin?
If 1 millimeter is free from tumor tissue.
Suppose I'm an excellent surgeon, I have made 0.5 millimeter negativity. Will that be adequate? So the definition again is no ink on tumor, meaning that the tumor after you take out, they dip it in ink and then they do the gross slicing. So the surface cells will always have ink and the inner cells will never have ink. So when you examine them under the microscope, if a single tumor cell has ink on it, that means it is right at the surface, and that tells you it's a positive margin. So your answer will be 1 millimeter, 2 millimeter, all that is not important. Grossly, we take out a 1 centimeter margin, grossly, but under microscope, it should be no ink on tumor. That is the answer. Okay.
What is that ink? What is the name of that ink? It is India ink, isn't it? India ink. Okay.
Bala, do you have any questions to clarify or any doubts to clarify with the faculty here?
No, sir.
Yeah, I would like to just add 2 lines, Dr. Kanagavel, that for
please, sir, please go ahead.
Common things are common. So please remember to give a diagnosis in such a patient, you know, that carcinoma of the breast also should be your diagnosis. Just because there is a dilated vein and no nodes in the axilla pectoral fixation, you cannot say that it is a, you know, phylloids. You have to look at everything, age of the patient, everything.
Yes, sir.
Okay. And then you can't miss supraclavicular region, axilla, and skeletal, and all that thing. And as a investigation, I think including all the most of the benign tumors today, you know, core needle is standard. Core needle, not miss that. And mammogram, I think everything has been made very clear by madams today. So it is, but you yourself make one small flow chart, you know, especially carcinoma of the breast, very common problem. And you know, there are so much treatment available today with the chemotherapy, with the triple negative, HER2, so many situations. So you have to make yourself one small flow chart for 4 or 5 different situations. You have to say early lesion, what exactly the flow chart, age, premenopausal, postmenopausal. This situation, postmenopausal, 5 centimeter, larger lumps. So you yourself make a flow chart and try to understand it and think about it. Then your answering will be much better. That's all, sir, from my.
Bala, I would like you to share the final diagnosis of this patient with Dr. Kanagavel. I am very curious to know what the final diagnosis is. Yeah.
Yes, ma'am.
Okay. I'm done from my
Certainly,
side,
ma'am,
Mr.
certainly.
Kanagavel. If anybody else
And
wants.
Thank you. Thank you, Bala.
Thank you.
thank you, ma'am. I think
Thank you,
he's sir is right now with us. Anand sir, would you like to give your comments? I think he's left. Fine. Madam, I think we have to move on for want of time. Shamita ma'am and Shilpa ma'am, we would request you to stay back for the second case. I trust you have time, but then feel free to leave if you are other commitments. We have a epigastric mass being presented by Shubham from IMS Banaras University.
Yeah,
We move on to the next case.
Today we had an epigastric. We were conducting the MS exams and we had 2 epigastric masses.
Okay.
Yeah.
Wow, that's impressive. Right.
So I'll
right.
stay for a bit and
Anandi
then I'll
ma'am?
leave. Yeah.
I'm here, Kanagavel.
Sure. So, Anandi ma'am, would you like to tell something? Can we move on to the
No,
next
we can
case?
move on to the next case. Balakumar did his job well. Only
Yes,
thing he was not able to.
Bala, stay with
Yes,
us. Good luck to you. I think you face the questions with the poise, but then there are avenues where the examiners have pointed your deficiencies.
yes,
Please make note of it and study today itself so that we gain the knowledge deficiency to your favor. Good luck to you. And I also thank faculty and everyone who has kindly permitted to you, Jadhav sir and Anand sir, for permitting you to be here, especially Nishikant sir for grating you into this forum. Now we move on to the next case discussion. Dr. Shubham, he's a resident from JR from the IMS PHU. He's going to share his case presentation on the epigastric lump. Can we make it full screen, Shubham, and switch on your video, please?
Sir, my video is on, sir, and I think.
Perfect. Good luck to you. Make it full screen and start your presentation. Faculty, please take over.
Is it full screen now, sir?
Not yet.
No, sir.
Yeah, perfect. Good luck to you.
Thank you, sir. Good evening, respected faculty, teachers. Myself, Dr. Shubham Kumar Gupta, third-year resident from Department of General Surgery, Institute of Medical Sciences, BHU Varanasi. Professor Ajay Khanna sir is my moderator and mentor, and Professor Seema Khanna ma'am is my head of the department. My guide is Professor Sanjeev Kumar Gupta sir. So I'm presenting a case of epigastric lump. 42 years gentleman, farmer, factory worker by occupation, resident of Varanasi, Uttar Pradesh, presented with complaints of pain in upper abdomen 1 year back and fullness in the upper abdomen for 1 month, early satiety for 1 month. So coming to history of present illness, patient was apparently asymptomatic 1 year back when he developed pain in upper abdomen, which was within 24 hours of an episode of binge drinking and resulted in sudden onset acute severe abdominal pain radiating to back, rapidly progressive over 3 to 4 days, and then gradually subsided over next 2 to 3 weeks. This was associated with nausea and 2 episodes of non-bilious, non-projectile vomiting containing food particles and water, but not blood. This was not associated with meals. His symptoms got relieved with IV medication, and for this ailment he had to get admitted for 4 days in a private hospital. He had similar episode 2 months back that required hospitalization for 7 days and was managed conservatively without any intervention. Since then, he is having heaviness, more of a discomfort in the upper abdomen. For last 1 month, his diet has reduced from 4 to 5 chapatis per meal 2 to 3 chapatis per meal. He complains of postprandial fullness as well in the upper abdomen. This is not associated with loss of appetite. There is no history of fever, significant weight loss, loss of appetite, hematemesis melena, altered bowel habit, steatorrhea, or yellowish discoloration of eye and urine, blunt trauma to abdomen, or any history of chronic drug intake. He is not known diabetic, hypertensive, or do not have any other comorbidities. There is no surgical intervention in past. His family history is not contributory. Personal history, patient consumes mixed diet. He has normal sleep pattern, normal bladder and bowel habit. He's a chronic alcoholic. He has been consuming 150 to 200 ml of alcohol per day for 5 days a week with inter episodes of binge drinking. Last intake was 2 months back. He is non-smoker. So summarizing my history, 42 years gentleman, alcoholic, with history of 2 episodes of severe pain in upper abdomen radiating to back, associated with nausea and vomiting The first episode was 1 year back, and the last episode was 2 months back, requiring hospitalization. He has now presented to our OPD with history of discomfort in the upper abdomen for last 2 months, fullness in the upper abdomen, and early satiety for last 1 month.
Okay, we'll move on to the first slide.
Yes,
To start with, you said there is a pain in the upper abdomen 1 year back. Why should you put this 1 year back history in the complaints? You could have put it as a case of a recurrent abdominal pain. If he's having 2 episodes. Okay. Rather than putting in pain, see 1 year back, you can go it in your past history. It shouldn't come in the complaint. Complaint should be if there's going to be an upper abdominal pain now, then you can put it in the complaints.
Yes, ma'am.
Right. Okay. What is the reason for this early satiety?
It can be because of a pressure symptom, because of some that is mass effect compression.
Generally, what is the reason for an early satiety?
Ma'am, reduced distance ability of stomach results in early satiety. Now, this can be because of intraluminal pathology or gastric wall pathology, or it can be extraluminal pathology.
Very good. So we want the stomach to expand. When the stomach lacks its expansion, either because of a luminal involvement, when the mass is going to occupy that area, as you said, or it could be in mural involvement or an extraneous impression. So what do you think is your case is going to be?
Ma'am, presenting with the 2 episodes of pain suggestive of acute pancreatitis in this alcoholic patient. I'm keeping episodes of acute pancreatitis, which has resulted in sequelae of as a sequelae of which there is a pseudocyst, which might be compressing the stomach.
Okay, coming back to your
as
case.
result in the upper abdomen.
Right, you said pain in the upper abdomen. What are the causes of this pain in the upper abdomen due to?
Severe pain in upper abdomen can be because of, in this alcoholic patient, it can be because of Mallory Weiss tear, or it can be because of peptic ulcer disease, or it can be because of liver abscess, left liver abscess maybe.
No, Shubham. Is the pain recurrent or is it just one episode?
There were
Mallory Weiss will be recurrent or it will be a single episode?
No, sir. In this case, sir, it will be Mallory Weiss tear will be in not recurrent. But sir, ma'am asked the differentials of a pain in acute upper abdominal pain. That's why I was enumerating, sir. Not in this case.
The problem I'm asking about the pain in upper abdomen as a differential for this case.
So, ma'am, for this case, it can be either
one was
it
your
can be-
alcoholic pancreatitis, you told. What
yes,
could be the
ma'am.
other
Alcoholic
causes?
pancreatitis. It can be liver abscess, ma'am.
Liver abscess.
Liver abscess.
Okay.
Then it can be because of peptic ulcer disease.
Okay. Any possibility of a biliary pathology, gallstones?
Yes, ma'am. Gallstone, CBD stone may result in pain radiating to back compression. There can be also severe pain mimicking the pancreatitis.
So how do you rule out between a CBD stone and an alcoholic pancreatitis here?
Based upon history, ma'am, the patient will be having a history of colicky pain, maybe multiple episodes in past, which will be associated with, which may be associated with consumption of fatty food. And then there can be yellowish discoloration of eye and urine.
Not
This,
necessarily all cases need to produce an obstructive symptoms.
yes, ma'am.
Okay. Right. What do you mean by colicky pain?
Ma'am, colicky pain is because of the vigorous contraction of the smooth muscles which are present in the wall of the biliary tree, and the characteristics are it lasts for it is of sudden onset and lasts for 4 to 6 hours, and usually starts 2 to 4 hours, 2 to 3 hours after taking a fatty meal.
Shubham, you are missing one point.
Yes.
Hello.
Yes, sir.
Any other cause of pain in epigastric region that radiates back in alcoholic patient? Pain radiating to the back. Pain in the epigastric region and radiating to the back. I'm just asking cause.
Sir, means not in this case, but gastric perforation.
In general.
Sir, gastric perforation.
Madam's question was, what are the causes of pain in the epigastric region? That's why I'm asking.
Yes, sir. Sealed of gastric perforation, sir, may present with this scenario.
Okay, long duration pain. Is malignancy of pancreas present like this?
Yes, sir. Malignancy of pancreas may present like this, sir. Yes, sir. There will be chronic pain, sir.
Proceed.
May I make a small comment?
Yes,
Hello.
Please.
Yeah, just saying, especially if you're going to give examinations abroad, calling a patient an alcoholic is not taken very kindly. It's nicer to say that the patient has alcohol dependence or the patient is abusing alcohol, but so just keep that in mind whenever you're talking about any patient with addiction. Yeah.
Yes, ma'am.
Like a peptic ulcer, which may occur in a patient who is taking a lot of alcohol, can that cause the pancreatitis type of pain?
Sir, peptic ulcer. Sir, if it gets perforated, then it may present with mimicking acute abdomen.
What is the penetrating ulcer? Okay, ulcer can perforate usually on the anterior aspect.
Yes, sir.
Or it will penetrate on the posterior aspect.
Posterior aspect, yes, sir.
Then if somebody has got the GERD, gastroesophageal reflux is there, the patient is taking a lot of alcohol, that can also cause pain in the back also. Apart from the retrosternal pain which is there, it can also cause pain. So these are the other things you should keep in mind. That what are the causes of pain in the upper region which is radiating to the back.
Yes, sir.
Okay.
Yes.
We'll move on to the next slide. Anything there? Sure. Okay, next slide. This is all finished. Okay, we'll go on with the examination.
So the patient was examined in well-lit room after informed consent. He is conscious, cooperative, and well-oriented with time, place, and person, lying comfortably on the couch. His vitals at the time of examination were stable. He is of average build, fairly nourished, a BMI of 19.3. There is no pallor, cyanosis, jaundice, icterus, clubbing, cervical lymphadenopathy, or pededema. No stigmata of chronic liver disease was present. On examination of the abdomen, inspection.
1 second, Shubham. One thing in the history which I wanted to know, did you mention about any ball rolling movement? You said there was a fullness in the abdomen, upper abdomen. Did you mention about ball rolling movement?
No, ma'am, I did not mention, but patient did not complain of any visible peristalsis or ball rolling movement. No.
You're supposed to mention it, right, on your history. Like whenever there's going to be fullness in the upper abdomen, never forget to mention about it, right?
Okay.
So that you rule out a gastric outlet obstruction.
Gastric outlet obstruction, yes.
Right, that has to be mandatory. Right? Tell me some causes of ball rolling movement.
Ma'am, depending upon whether it is from left to right or it is from right to left, the direction, the pathology can be at different anatomical locations. It can be gastric outlet obstruction in case of left to right bowel rolling movement, which can be commonly because of cicatrizing duodenal ulcer, or it can be because of CA stomach involving the gastric outlet. It can also be because of the carcinoma head of the pancreas and other tumors arising from the head of the pancreas. However, the ball rolling movement, if it is present from right to left, then the pathology usually lies in the left colon, and this can be because of left colonic malignancy that are stenosing variety.
Okay, go ahead. The examination, inspection.
On inspection, fullness was present in the epigastric region. In the epigastrium, which became less pronounced on head raising test. Umbilicus is inverted midline, but displaced somehow downwards. All quadrants were moving proportionately with respiration. There is no scar or venous engorgement noted. There is no visible peristalsis or pulsation. Hernial sites were intact. On palpation, there is no local rise of temperature or tenderness. A lump of size 8 by 10 centimeter, mainly in the epigastric region, extending into the umbilical region, that became less prominent on head raising but did not fall forward on lateral decubitus. It was firm in consistency, smooth surface, well-defined margins. Fingers can be insinuated between the lump and the bilateral costal margins. It was non-mobile and did not even move with respiration. There was no transmitted pulsation. No organomegaly was noted on palpation. On percussion, liver span measured 11 centimeter in the right midclavicular line, starting from the fifth intercostal space. There was a resonant node audible over the lump. There is no evidence of free fluid in the abdomen. On auscultation, there was normal bowel sounds audible. DRE, there was no significant finding. The findings were within normal limit. Renal angle were normal. Examination of spine was normal, and external genitalia were normal. Systemic examination, central nervous system revealed intact higher function, and there was no neurodeficit. Cardiovascular system and respiratory system were within normal limit. So summarizing my case, 42 years gentleman, alcohol dependence for last 6 years, with history of 2 episodes of severe pain in upper abdomen radiating to back associated with nausea and vomiting. The first episode was 1 year back and the last was 2 months back, which required hospitalization. Has now presented with discomfort in the upper abdomen for last 2 months, fullness in the upper abdomen associated with early satiety for last 1 month. On examination, a firm 8 by 10 centimeter retroperitoneal lump was palpable in the epigastric region, extending into the umbilical region with well-defined margins, firm in consistency, smooth surface with no intrinsic mobility nor moving with respiration. The resonant node was audible over the lump on percussion. Should I move move forward.
Hello, Shubham.
Yeah,
Yes,
what
sir.
is your diagnosis? And then go back to your inspection slide. What's your diagnosis? Just complete your diagnosis.
So based upon history and examination, I have kept my provisional diagnosis as pseudocyst of pancreas,
Okay,
and
yeah,
differentials are, yes,
yeah,
sir.
okay, that will okay, but just go quickly to the inspection slide. Yeah, just. I think, yes, what is important is as soon as you see this patient, you saw that fullness, that is fine. But the second part is probably not required at this stage. Okay. You know, you just inspect the abdomen, spend some time. Patient is lying supine, is in front of you. So you have a look at that. All right. Spend
Yes,
some
sir.
time. So
Yes, sir.
you can just coolly say there is fullness in the epigastrium. Whatever, if you have seen it umbilical, that's fine. Then rest of the things, umbilicus, yes, you are written here displaced downwards. But if you look at your next, can you show the next slide? So this is looks very small actually comparatively, but I cannot comment because since we have seen the umbilicus displacing downwards, this fine. Go back to the first slide.
Sir, previous slide.
Go back to the first slide. Yeah, so all quadrants move, all that you have written, no scar, venous engorgement. These few things are important here to mention. What is the scar and what is this venous engorgement? Why did you suddenly bring that?
Sir, there are two things in this context. Since the patient is alcohol dependent, there might be features of portal hypertension associated with chronic liver disease, or it can be because of, sir, retroperitoneal swelling compressing upon IVC, and then there can be prominence of anterior abdominal wall veins. So these two were.
Yes. So instead of trying to straight away venous engorgement, see, certain words very important here. You can be specific here. Since you would like to comment on the umbilicus, we are written inverted, all that thing. You don't have to say venous engorgement. You can say dilated veins or whatever it is. Or you can say even no caput nodosum in particular. See, we are expecting a large retroperitoneal mass causing IVC compressions. We should not, if it is there, you tell. Okay. What is that scar you would like to say? Scar.
It was more for a completion sake, sir, because of stretching of the abdomen, because of abdominal distension. However, there was no such findings. It was more for a completion sake, sir.
Yeah, okay, so I understood what you were trying to tell. So it is important here to mention flanks fullness. Why is that?
Yes, sir. Yes, sir, because all patients in early patients having ascites in an early phase will present in the fullness in the flank rather than the abdominal distension as such. So which can be evident on inspection, flank fullness.
Since your patient is you said alcohol.
Yes, sir. Alcohol dependent.
Even though you have written that no evidence of chronic liver disease. So yes, we would like to specifically look into these things first. Okay.
Yes, sir.
That is what I am trying to tell. So this because in the next slide itself, we already mentioned on head raising test again, correct?
Yeah.
Yes, sir.
Correct. So that is the reason
sir.
I mentioned. That's all. These are some few comments on this inspection slides. That's all.
See, whenever you do an complete examination, you're supposed to mention about the scrotum. You're not told about the.
Ma'am, I have mentioned about external genitalia.
External genitalia doesn't come under scrotum. Scrotum and testis comes under the separate entity.
Okay.
Okay, because when you have a testicular swelling, there could be an paralytic node.
Yes,
so
ma'am.
you
Yes,
need
ma'am.
to specifically mention about whether the scrotum and testis are normal separately, right?
Yes, ma'am.
That has to be mentioned. That is not there.
Yes, ma'am.
Shubham.
Yes, sir. Yes, sir.
You are not mentioned depth supraclavicular area. Depth supraclavicular fullness. That is
sir, I did not specify that, but in
that is a part of the examination. That is included. As just now, madam said that scrotum, external genitalia, and left supraclavicular lymph node, spine, and renal angle. These are the four important components of the complete abdominal examination.
Yes, sir.
Okay.
Okay, on examination, if this mass is going to be retroperitoneum, but it is moving with respiration, what are the possibilities you think of?
Ma'am, a big retroperitoneal mass which is in contact with the diaphragm may move with respiration, may show some mobility with respiration, ma'am.
Which big mass is going to be?
Ma'am, like a large pseudocyst may show some mobility if it is in contact with the diaphragm. I'm extending up to diaphragm.
Okay. Apart from that, any other retroperitoneal mass which can move with respiration?
Ma'am, retroperitoneal mass that can move with respiration. Ma'am,
not in midline.
Ma'am, renal mass can move with respiration.
Yeah, renal mass can move with respiration at times. Right?
Yes, ma'am.
Shubham, a pseudocyst, no matter how close to the diaphragm it is, it's not going to move with respiration. By the and you will get into trouble because you'll be asked the various compartments of the peritoneum and stuff like that. So pseudocysts will not move with any attachment to the diaphragm or otherwise. Kidneys, like ma'am said, yes, definitely large kidneys, but never a pseudocyst.
Okay.
You said the transmitted pulsation, isn't?
Yes, sir.
So what are the other pulsations you can get in that area?
Sir, one can get a transmitted pulsation or expansile pulsation, sir.
So how will you differentiate between a transmitted and the expansile pulsation?
Sir, the underlying etiology helps us to differentiate between the two. In the transmitted pulsation, if the swelling is small, or then we can see that it is because of in close proximity with a vascular structure, like aorta in this case, then there may be transmitted pulsation even in the pseudocyst. Which can be seen that the fingers which are placed, like if the hand is placed enclosing the abdomen and the fingers, the thumbs are close apart. So there will be separation of the two thumbs. This will be transmitted pulsation. However, in case of expansile pulsation, there will be the separation of the finger as well as lifting of the finger because of a vascular, the lesion arising itself from the aorta, such as a large aortic aneurysm.
Is that the way to do in the big epigastric lump? Because this test which is there, putting the two fingers, whether it is moving
It's
just
for a small lump, sir.
Moving apart, no, that is not for the big lump in the epigastrium.
So there is another test. We can see whether the lump will fall forward and from the underlying vessel, and then the transmitted pulsation will disappear. However, it was previously done in knee elbow position, and it is not a comfortable position for the patient. But in left lateral position, yes, we can. In a lateral decubitus, we can.
The only way to differentiate, yes. You cannot differentiate by putting the two fingers there. Okay. So you make the patient left lateral or knee elbow.
And the lump fall forwards.
Yeah.
Yes.
If you feel still the pulsations, then it is expansile. If it are not there, then it is a transmitted one.
Yes.
Okay. Coming on to percussion, you said your mass is resonant on percussion. How do you explain?
Madam, based upon palpation, I was anticipating that this was a retroperitoneal lump, so it must have come forward, and the overlying viscera, which is a stomach in this case. So because of the gas in because being a hollow viscous, there was a resonant node which was audible on percussion. So there can be a dull note also if the lump is large, very large, so that it compresses entirely the stomach.
Yeah, your mass is almost 8 × 10 centimeter. Definitely, it's kind of huge lump. Definitely, yes, pushing your stomach upwards, right? So yes, definitely, you will not have a complete normal resonant node. Yes, the resonance might be impaired.
Impaired,
node.
yes, ma'am.
Yeah, so you can write it as an impaired resonant node if you are able to hear it,
Yes,
right?
ma'am. I should have written it impaired, yes, ma'am.
Rather than putting it as a resonant node.
Yes, ma'am.
Right. Okay, how, sir, can we move forward, sir?
You said the diagnosis of pseudopancreatic cyst, isn't? Is the pseudopancreatic cyst more common in the chronic pancreatitis or acute pancreatitis?
So it is more common in acute pancreatitis, sir.
Are you sure about that?
Chronic, sir.
It is more common in the chronic pancreatitis.
Yes, sir. Chronic pancreatitis.
In the acute pancreatitis, what you get is the fluid collection.
Acute fluid collection, yes, sir.
But the pseudopancreatitis cyst which is there, it is more common in the chronic pancreatitis.
Yes, sir.
Now, if a patient has a gallstone, will it cause acute pancreatitis or chronic pancreatitis?
Gallstone will cause acute pancreatitis, sir. Recurrent episodes of acute pancreatitis may result in chronic pancreatitis, but it will cause acute pancreatitis.
Okay. What is the commonest cause of the chronic pancreatitis?
Sir, alcoholic pancreatitis, sir.
Alcoholic.
Yes, sir.
So gallstone pancreatitis, gallstone usually doesn't cause the chronic pancreatitis. It causes
Yes,
the
sir.
acute pancreatitis.
Yes, sir.
Okay. You can go ahead now. Yeah.
Then
my as an extension of clinical examination, I would like to do a ultrasonography of the abdomen for this patient, and would like to see if the patient, what is the location of the lesion, the anatomical origin, the anatomical organ of origin, the size of the lesion, then the number of the lesion, the wall thickness, the content, its relation with the other structures, structures in the vicinity. Then the status of the pancreas, if pancreatic parenchyma, if visible, and then pancreatic duct, main pancreatic duct, if it is dilated or not, or if there is any stones or not. Then we can, as the patient is alcohol dependent, so I must see the liver echo texture, and will also rule out any associated, if there is any GB sludge or gallbladder stone or CBD stone. CBD stone less likely, gallbladder stone mostly. Then using the Doppler, I would like to see the vascularity of the lesion. Then the vascularity of the wall, and then collaterals, if any, and the associated the vessels which are in the surrounding. I would like to see if there is any pseudoaneurysm or thrombus in the vessels. So these are the, with these intentions, I would like to subject the patient for ultrasound of the abdomen.
okay, from the ultrasound of the abdomen, how do you differentiate this, because whether it is due to an acute collection or a chronic collection?
Ma'am, from ultrasound, in an interstitial pancreatitis, if the duration is less than 4 weeks or more than 4 weeks, less than 4 weeks goes in case of acute peripancreatic collection, and more than 4 weeks goes in favor of the pseudocyst of the pancreas, then the wall is well defined in case of pseudocyst, and it is rather poorly defined or not present at all in case of the normal facial boundaries are the limits for the acute peripancreatic collection. Then the third feature is the there is no both of them are both of them are homogeneous, homoechoic. Better to say anechoic. Then
see what happens in a pseudocyst. Usually, what happens, it will be homogeneous, as you said.
yes,
Whereas in a case of a necrosis, it won't be that homogeneous. There will be multiple
there will be
pockets, which might be, you'll be able to appreciate in between. So you need to
Yes,
look
ma'am.
for those things, and in case of an acute necrosis.
yes,
Right.
ma'am. Yes, ma'am.
Fine. So what was the earlier investigation which was done to diagnose a pseudocyst?
Ma'am, now I would like to take this patient for CCT abdomen to confirm the lesion, and then the points which I said. Along with that, we'll confirm its relation with the surrounding structure, because that will help me to plan the management.
Okay, if you want to do an X-ray, will it help to diagnose a pseudocyst?
It will be helpful in case of chronic pancreatitis, where we can see the calcifications in the pancreatic, the calcifications or the stones which can be evident, ma'am, in X-ray.
How, Shubham, how would you diagnose that the patient has had a bleed? You said you would look at the splenic artery and you would look for other. So what are the signs you would see within the cyst, or what are the clinical signs which would suggest that there's a bleed?
Ma'am, clinical signs will be a retroperitoneal hemorrhage, which will be manifesting as a Cullen sign and then Fox sign. That is the periumbilical ecchymosis, flank ecchymosis. Then along the inguinal ligament, there can be ecchymosis. These are the clinical signs, and then of course the patient might have shock and the hemoperitoneum tenderness, peritonitis-like feature with the unstable vitals. Then in case of the radiological signs, if we talk about, I was talking about pseudoaneurysm of splenic artery. Yes, ma'am. Then regarding the vascularity, actually, there is increased vascularity to differentiate it from the cystic neoplasm, and also if there is increased vascularity, may also show ongoing inflammation, though in this case I don't think there is ongoing inflammation, as the patient has no features of inflammatory response going on. Then there can be thrombus as a vascular event, as a complication.
Yeah. So all that would be visible only on a triple phase CECT, no?
Ma'am, triple phase CCT, ma'am, here at our institute we do triple phase CCT to when we are doubtful to differentiate it from either pancreatic neuroendocrine tumor or from the cystic neoplasm of pancreas. In pseudocyst of pancreas, we can only do a CCT whole abdomen, and the Doppler will help us. USG Doppler will give us a good idea about this clinic.
You seem to have very good radiologists. I'm happy about that. But we routinely do a triple phase to figure out if there is any venous or arterial issues, as well as whether the cyst enhances this, so we know whether there has been a bleed. We know whether there is something other than the cyst. So, I mean, that's just a routine protocol we follow with us. But yeah, go ahead.
Dr. Shubham, I would like to ask you one or two questions. What is the role of MRI in this case, or in general here, pseudocyst?
Sir, MRI has following indications. First, the advantage is that it shows if there is any solid component inside a cyst, it will be better delineated on the MRI as compared to CECT. Then second comes if the patient has obstructive jaundice, we want to see the extrabiliary tree or the site of obstruction, say for instance, then we have to consider MRI. And third, if we want to see any ductal communication, the main pancreatic duct communication with the cyst, then of course MRCP will be a better modality, sir.
So both common bile duct, that diameter of the common bile duct.
Yes, sir. Yes,
diameter of the pancreatic duct. So better delineated by MRI in case if you want to have a ductal communication, which is likely in sometimes in chronic pancreatitis and even in a trauma. Okay.
Trauma cases, yes.
One other question. What other advantage? You mentioned so many advantages of CCT over ultrasound. In keeping in mind, if it is a chronic pancreatitis and patient has early satiety, and suppose there is a pseudocyst and possibility of head mass, what do you suspect?
Sir, it can be intraductal papillary mucinous neoplasm, which might mimic
carcinoma of the pancreas.
Carcinoma of the pancreas, sir. As the patient is, sir, 46 years, so.
No. That probably is not the thing. What I'm not trying to say in your case, what I'm trying to tell is that
yes, sir.
Additional advantage of the CT scan, over the ultrasound in a case like this.
Sir.
So especially in addition, you can also see any head masses, including any malignancy. So that's where comes the differentiating point, like tumor markers, in case if it is required. May not be in this particular situation. Okay. So will you do endosonography in this patient?
Yes, sir. Upper GI endoscopy along with ultrasonography will be very helpful. Starting from the fact that he is alcohol dependent, so there can be a associated varices which may be a hurdle, maybe a little bit challenging while we are operating on the patient. Also, the relationship with the cyst wall and the gastric wall, posterior wall of the stomach, what is the distance between these two will help us to decide the management, whether we can go for endoscopic or we have to go for a surgical intervention. And apart from that, sir, it helps also to distinguish between the cystic neoplasm from the pseudopancreatic cyst. Pseudocyst of pancreas, pseudocyst of pancreas. The vascularity can be assessed by the Doppler, which is now available with the endoscopic ultrasound. And guided aspiration can be done of the cystic fluid, which can be subjected to various investigations, which will be helpful. Sir. So these are the advantages of doing. Of course, sir, it is therapeutic also.
Sorry, you said you would this is a patient of recurrent episodes of pancreatitis, right?
Yes, ma'am. Yes, ma'am.
So Dr. Saab ne pucha tha whether you do an MRCP. So would MRCP be part of your protocol in a patient of chronic pancreatitis? Do you know the grades of pseudocysts based on MRCP?
Yes, ma'am. It is grade 1, 2, 3, and 4. In grade 1, there is normal pancreatic duct.
7 grades.
Sorry, ma'am. I'm not been aware of it, ma'am.
Yeah, the Nealon classification, there are 7 grades.
I know 1, 2, 3, 4, and then A and B in each of it, ma'am.
Okay, what is the 1, 2, 3, 4? That is the older classification.
Sorry,
okay, that is in fact 3. Those are 3 classifications. The later one has got 7 classifications. So essentially, you want to know whether there is communication with the cyst,
yes, ma'am.
Whether there is a stricture formation, whether there is signs of chronic pancreatitis. I mean, read it up. There are I can't remember all 7 of them. But whether there is chronic pancreatitis with or without duct cyst communication, whether there is
dissociated ductal syndrome.
Yeah, yes, so that there is this Nealon classification. Read it up. Yes, there are 7 pointers, which is why when we diagnose a patient of chronic pancreatitis, we always do an MRCP to put the patient in a specific group and then take the treatment forward.
Yes, ma'am. Yes.
Yeah.
Yes, ma'am. Yes, ma'am.
Okay, go on.
Shubham, what are the causes of portal in a case of a pseudopancreatic cyst?
Sir, causes of
portal hypertension.
What is the
pathogenesis of hypertension in pseudopancreatic cyst? How does the portal hypertension occurs in a pseudopancreatic cyst?
Sir, it can be because of external compression over the splenic vessels, which will or portal vein which will result in stasis and thrombus formation, or it can be because of so external compression or thrombosis. These 2 are the things which is coming to my mind.
What is biliary cirrhosis?
Sir, biliary cirrhosis is because of back pressure, sir. There is hepatocellular, there is stasis and hepatocellular failure. Hepatic hydrops like things occurs, and then there is
CVD stones. Okay.
Sir.
On one, the pseudopancreatic cyst. Other way, it can cause the biliary cirrhosis.
Yes,
And
sir. Biliary cirrhosis.
of the portal hypertension.
Yes, sir. Yes, sir.
Hello,
Shubham.
Shubham.
Splenic thrombosis may be there.
Yes, sir.
Splenic thrombosis may be the cause for the portal hypertension.
Yes, sir.
Shubham, what are the deficiencies of a CT when you're doing a CT for pancreas like this? What are the possible issues that can happen?
Please repeat. Would you
Especially
please
a
repeat your question?
contrast CT. If you do a CECT, what
Yes,
can
ma'am.
happen?
Ma'am, we have to take into account the patient should be well hydrated and the creat should be normal,
Okay.
or at least upper limit of normal.
And
then,
what is its
that
limitation? What is the limitation
of using contrast, ma'am, or limitation of
a
CT?
CT? Yeah, CT.
Ma'am, limitation of CT, the ductal the main pancreatic duct communication may not be that much evident, ma'am.
That's one.
And,
that's one.
Then if there is a necrotic component in the cyst, it might get missed on CT. That is the other thing.
No, the other
And,
thing is that it is very difficult to differentiate a pseudocyst from cystic neoplasms of the pancreas. Okay, a cystadenoma or a mucinous cystic neoplasm. So how would you differentiate these entities based on blood investigations or anything else?
Madam, regarding the radiological features, in this case, the differential is intraductal papillary mucinous neoplasm, which on CT appears a lobulated and then rather poorly demarcated polycystic mass-like with dilated
Yeah, but
pancreatic duct.
it's still got a very high rate
Then,
of
yes, ma'am. Yes,
no,
ma'am. Then
so are there any
in
other
that case,
investigations that will
yes,
help you?
I will go for a USG endoscopic guided USG guided aspiration of the cystic fluid and subject it for culture and sensitivity. The mucin level,
Culture
amylase level,
sensitivity.
and then
Okay, amylase will be
just for an amylase level, and then for CEA level. Now, in case of pseudocyst of pancreas, the amylase level may be raised, mucin level is normal, and then the CEA is normal.
One second. You're confused. CA will be raised in which?
CEA will be raised in case of mucinous neoplasm. That is intraductal papillary neoplasm.
Okay, fair enough.
All the three will be raised. All three will be raised in case of mucinous, intraductal papillary mucinous neoplasm.
Which three will be raised?
Ma'am, amylase, mucin, and CEA. All three will be raised.
What about CA 125?
Ma'am, CA 125, it is more raised. It can be raised in case of mucinous neoplasm, ma'am, because of
No,
presence
not
of
all mucinous. If it's only a mucinous cyst, it's a adenocarcinoma.
With ovarian.
If it's a carcinoma, not all mucinous cysts will
Yes,
have
ma'am.
a raised. So if you want to diagnose a mucinous cyst, then you will do a CA 125. Anything else?
Yes,
CA 99?
CA 99 can also be done, ma'am. And then there are genetic markers that can be done, like
No.
MUC.
You answer my question. What happens to CA 99 in serous, mucinous, and pseudocysts?
Ma'am, CA 99 is raised in case of mucinous cystic neoplasm, ma'am.
Yeah. So it's easier to get a diagnosis of a mucinous with all the blood markers and an amylase and lipase. Yeah.
Yes, ma'am.
So you can do that as well. In addition, if you're listing on a CT, because CT cannot really put a pinpoint diagnosis of one of these.
Yes, ma'am.
Yeah.
Yes, ma'am.
And then you can talk about your other markers now. What else were you talking about?
Ma'am, I was talking about the staining.
Okay. Anything else? Any other markers?
Ma'am, in case of intraductal papillary, one can go for MUC6 and then MUC2, MUC5AC. These are the markers. Then in case of serous cystic neoplasm, one can go for PSA staining. In case of pseudo papillary, one can go for CD10, vermentine, or NSE, non-specific enolase, and beta carotene.
Okay, let's come to the
in case-
commoner investigations. What is the level of your CA for it to be very
Yes, yes.
well specific?
Yes, yes.
Like,
ma'am, to
at
be
what
very well
levels?
specific, it should be, ma'am, to be very well specific, it should be more than 400. But the cutoff which is given there is 192 nanogram per DL. To
It's
call
much.
it whether it is a mucinous or
no,
non-mucinous.
no, we are not talking about blood. No, we are talking about the cystic carbohydrate antigens. No, the 99 for the cyst. I'm not talking about blood.
For the cyst CEA level, ma'am, I was telling,
So,
maybe I'm wrong, ma'am.
It has to be more
tell me.
than 50,000 units per ml for it to be specific to a degree of 90+%. Okay, what about the levels of the CEA levels are less than 5 nanograms is, you can rule it out. Okay,
No, yes,
and
ma'am.
carbohydrate
Yes, ma'am.
antigens have to be 99, have to be more than 50,000. Okay, so
Okay.
CA
Yes,
levels
ma'am.
of
Thank you.
less than 5 rule out a malignancy, and 99 more than 50,000 confirm a diagnosis. Okay.
Yes, ma'am. Thank you.
Yeah.
Hello, Shubham.
Yes, sir.
You have not mentioned about cyst wall thickness. What is significance of this?
Sir, cyst
On
wall
CT
thickness,
scan.
sir, I've mentioned about cyst wall thickness, sir. Cyst wall thickness of less than 6 mm will not hold sutures well. So
Okay.
the cyst wall should be matured for going for a surgical intervention so that it holds suture well. So
Okay.
more than 6 mm is
So
desirable.
how do you plan to drain your pseudocyst?
Madam, this patient is symptomatic, but there is no signs of infection. So at this point of time, I would surely involve gastroenterologist, my gastroenterologist colleague in the management. Along with the patient, I will discuss the various options such as endoscopy. He can have an endoscopic management or a surgical management, both open or laparoscopic. We'll discuss with the patient, and we'll tell him that endoscopic is probably the better investigation, the better treatment modality these days. And then his choice
So
will
what is
be.
the criteria you need to look for when you want to choose for an endoscopic aspiration?
Ashutosh?
Endoscopic, ma'am, we have to see what is the distance between the cyst wall and the stomach wall. If it is less than 1 centimeter, then we can gastroenterologist can go ahead with the lumen opposing stent placement with the double pigtail insertion. And if it is more than 1 centimeter, then we have to consider the surgical management.
We need to see where the first mass is located, whether it is at the head
Yes.
or at the body or at the tail, and then
Yes,
whether it
ma'am.
is in close approximation with that of
With
your
which
stomach wall.
yes, ma'am.
Right.
Yes, ma'am.
Okay. If ma'am wanted to add something. Okay, how do you plan to go ahead and surgery? If you're planning in for a surgery, what do you think the steps could be?
Madam, discussing the steps for means I would like to go for a cystogastrostomy in this patient, where I will open the anterior abdominal wall where I will open the anterior wall of the stomach, and then will see the most bulging point on the posterior wall of the stomach. Will cross it, will take the help of CT intraoperatively. Then will make a 4 centimeter incision, 4 centimeter window between the cyst wall and the stomach wall. And using the non-absorbable suture, I would like to using non-absorbable matrix suturing, I would like to suture together the posterior wall of the stomach and the cyst wall. Will close the anterior wall of the stomach, and will place a drain and come out.
Shubham, why did you decide for surgery in this patient?
Ma'am, I did not decide. I will discuss with the patient, and based upon the endoscopic Ma'am actually asked about the surgical technique.
Oh, I'm sorry. Okay.
When you're going into the technique, when you do the opening of the anterior wall, it's call it as a gastrostomy. After opening up, then you said you look at the bulging point. First thing you need to
Yes,
put in a
ma'am.
needle and aspirate it and check
Aspiration and yes, ma'am. Collect the fluid. Yes, ma'am. Sorry, I missed that.
Then you
Yes,
need to
ma'am.
make stay
Yes, ma'am.
sutures.
Yes,
So that
ma'am.
you
Stay
don't,
sutures.
the wall doesn't leave
Collapse.
right. First you need
Yes,
to
ma'am.
take
Yes,
it
ma'am.
in hand, and then only you need to open up, and then you need
Yes,
to fix it up with you.
Yes, ma'am. Yes, ma'am.
Do you prefer to use always a non-absorbable sutures here? Why? What will happen to the wall at a later date?
Ma'am, there can be obliteration of this, means the closure of the wall may happen. There can be leak.
See, when we do
Which can happen.
endoscopy after some time, say after 6 weeks or after 2 or 3 months, we never see any hole at all there. Everything is
Yes, ma'am.
fused and it becomes almost a normal area.
Yes, ma'am.
Right?
Yes,
No
ma'am.
need to put in a non-absorbable suture. You can use
Okay.
absorbable suture like a white absorbable suture.
Sorry, ma'am, I could not catch.
A delayed
We can
absorbable
use.
sutures like a white
Okay.
can be
Okay,
used
ma'am.
to
Okay.
secure the sutures between the walls. Okay.
Okay, ma'am.
So when you're going
Okay.
to aspirate it, right? What are
Yes,
the
ma'am.
precautions you need to take? You made an incision.
Yes,
Now
ma'am.
what will you do? The fluid is gushing out. Now what will you do?
Ma'am, the spillage of the fluid in the abdominal cavity should be avoided. The assistant must be ready with the suction. The stay sutures help in keeping it there, and then we'll collect the fluid and
you
will.
need to anticipate at this junction.
There can be hemorrhagic fluid also. There can be intracystic bleed.
Sometimes there might be a lot of veins which might be underlying this wall, right?
Yes, ma'am.
So
Yes,
then
ma'am.
you should not put your hand too much inside and meddle within this
Yes,
cavity and break up these veins, right?
Yes, sir.
It might
They are very
result in
fragile.
a
Yes, ma'am.
severe bleeding. So you need to be
Yes,
very
ma'am.
gentle when you're handling these areas. Just put a suction and try to suck out all these things and
Yes, ma'am.
do a closure of these things, right?
Yes, yes, ma'am.
Does the food enter into this cavity?
Surprisingly, ma'am, the food doesn't enter into the cavity. The gravity dependence may be one of the factor. However, it might be because of intra-abdominal pressure. The exact mechanism is not known, but it has been observed that the food doesn't enter this cavity. If it is, I'm not aware of, ma'am, why it does not enter.
There are a lot of theories behind that. People say a lot of
Yes, ma'am.
stories why it doesn't go inside. Some
Yes,
say
ma'am.
that because of the folds of Magenster say along the gastric wall, it directs it down. So it doesn't enter inside the cavity. Some say it is because of the Venturi effect. The pressure which is there, it doesn't suck in. It tries to push it out.
Push
So
it out.
these
Yes,
are theories, but all not proven beyond. Right.
yes, ma'am.
When I was asking about the X-ray, right, there is one sign
Yes, ma'am.
associated with it. What is Beige sign?
Bait sign, ma'am.
Yeah.
Sorry, ma'am, I don't know, ma'am. Please
When you
help me with the answer.
Yeah, when you put a Ryle's tube, what happens? The Ryle's
Yes, ma'am.
tube would be very much anteriorly placed, and you can roll the Ryle's tube over the thin abdominal wall. Right? Since the stomach is pushed very much anteriorly in a very huge pseudocyst.
Yes, ma'am.
Okay. And whenever those days before the advent of the CT and other things as a routine practice, people were taking an
ma'am.
X-ray only to diagnose a pseudocyst. When the Ryle's tube lies in approximation with that of the vertebral column, that means there is nothing interfering between the stomach and that of the vertebral column. If there is a pseudocyst lying at that junction, what happens? The stomach is pushed anteriorly, so your Ryle's tube also gets shifted anteriorly. Right? So that will help to diagnose whether it's going to be a pseudocyst. That was the diagnosis done those days.
Thank you, ma'am. I didn't knew that.
Can I give it, sir?
What are the other ways to treat this cyst?
So there are endoscopic modalities. There are open and laparoscopic surgical techniques. Among the endoscopic, one can go for transmural approach or transpapillary approach, provided there is a communication between the cyst wall and the main pancreatic duct. Then in laparoscopic or surgical approach, among the surgical approach, one can go for gastroduodenostomy, cystoduodenostomy, cystogastrostomy, cystogegenostomy, or with Roux-en-Y limb of cystogegenostomy, depending upon its relationship with the various structures.
What are the various locations of the pseudopancreatic cyst?
Sir, it can be on the lesser sac, it can be in the pelvis, it can be along the, it can be in relation with the tail of the pancreas, near the extending near the splenic hilum. It can even go into the mediastinum.
According to the locations, it is a retrogastric, it can be retroduodenal, or it can be gastrohepatic, or it can be gastrocolic. Which is the 4 described locations of the pseudo. Then it can be occurring anywhere, and it may be going anywhere it can go, but these are the 4 common locations. So when do you do a cystogegenostomy?
Sir, when it is gastrocol, sir, the 4th one which you said, sir,
The gastrocolic variety is there.
Gastrocolic, yes, sir.
Then in that case, the preferred will be the jejenostomy.
Jejenostomy, yes, sir. If it is retroduodenal, then we can go for cystoduodenostomy.
Okay. Now,
gastrohepatic variety, sir.
When you are entering inside the pseudocyst there and you find all blood there in that area, what you will do?
As soon as I enter the pseudocyst, there is blood, sir.
Yeah.
Sir, I will see the nature of the blood. If it is altered blood, this suggests a hemorrhage which has happened in past, and if there is fresh bleeding, then it is whether it is a red bleed, rapid filling, or that is of arterial source, and or it can be the vascular, the venous source, which can be because of the tearing of the fragile walls, the fragile veins which are present in the wall. So these are the 3 things which I have to consider, sir.
Majority of the time, if you find that the hemorrhagic thing is there, do not be heroic at that time. It will be much better that you close that area and go to your interventional radiologist chair. Shift the patient to the interventional radiology department to carry out the activity. Okay, rather than
embolization, yes.
Right.
Yes. Yes.
Shubham, what are the criteria that decide whether a pseudocyst will regress or otherwise?
Madam, a pseudocyst of acute pancreatitis, or because of acute pancreatitis, may resolve. A pseudocyst which has a size of less than 6 centimeter will resolve. A pseudocyst of less than 6 mm wall thickness, or there is not a very well demarcation between the pseudocyst wall and the wall of the surrounding viscera, then the surrounding hollow viscous, then it may resolve. If there is communication with the pancreatic duct, then it may get drained. And
yeah, so you basically said pseudocysts of the head tend to resolve much better than pseudocysts of the rest of the body, and like you mentioned, extrapancreatic pseudocysts retain themselves, whereas intrapancreatic usually resolve. Those are the only 2 actually independent. Everything else is subjective. So that's where you can give a trial of conservation irrespective of the thickness of wall, because they might resolve. Other than that, and I think in today's era, I think the role of surgical management of pseudocysts is pretty much dying out. There's hardly anybody who's doing it, and there's increased mortality, increased morbidity. So the first line would be EUS, the second would be just percutaneous drainage. and very, very few cysts would actually go in for surgery. When you're giving an exam, that's what you need to specifically answer.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, Dr. Kanagavel, I think you should come in. We are done.
Sure. I've been listening to this voice. He was able to face almost all the questions. And I think we should allow
very well
Shubham.
presented, very confident.
Correct.
A tweak of extra confidence at a couple of points, which can irritate a few examiners, but an excellent presentation. I enjoyed myself.
That's the standard of IMS DHU, which has set, madam, the teaching standards of IMS. IMS
I should send my candidates there.
Thank you, madam.
Every day grilling of teaching and the intensive 3 years of training has shaped him to such a brilliant presenter. Shubham, do you have any doubts to get clarified?
No, sir. Just I want to thank Ajay Khanna, sir, for being the epitome of my surgical residency, and my guide, Professor Sanjeev Kumar Gupta, sir, for his constant motivation and support to me. And of course, you, sir. This is the 4th time I'm presenting in last 1 year, sir. And you are always kind enough to provide me with this slot whenever I express my intentions or request to present the case. Thank you so much,
Good
sir.
luck to you for the upcoming exams. And
thank you so much, sir.
I wish you all the best and wish
Shubham
to take
has, Shubham has finished the theory examination.
Yes, sir.
In 2 weeks' time, he will have the practical examination. And Shubham is one of the, out of all the 20 students which are there, he's one of the best students which is there, and he's really keen to learn everything.
Perfect, sir. Perfect.
He's the only one who will ask question again and again, and what Dr. Shilpa madam said, that sometimes he becomes very overconfident.
I understand.
And that makes the examiner sometimes irritative for that, yeah. So that is my advice also to the Shubham, and also Dr. Shilpa's advice is there, that do not try to be very overconfident for these things, okay? Yeah.
Thank you, sir.
Thank you very much, sir. I think we will call the session to close. Anandi ma'am, would you like to say something? Shilpa ma'am, thank you. Anandi ma'am, thank you. And I could see Sahai sir with us, and Khanna sir, thank you very much. We look forward for yet another edition in the coming Friday. Good night, everyone.
Good night.